Bismillahirrahmanirrahim. Today we are going to start the topic of chronic obstructive pulmonary diseases from the respiratory system. So what will be the contents of the lecture? We will first discuss the epidemiology and then the definition, the risk factors, the pathogenesis, pathology, classification, the management of the chronic obstructive pulmonary diseases and their exacerbations. So now coming to the epidemiology. The most common cause of chronic obstructive pulmonary diseases is cigarette smoking, and the World Health Organization estimates approximately 1.3 billion smokers worldwide, and it is increasing to approximately 2 billion by 2025. And in 2000, the WHO estimated approximately 2.74 million deaths worldwide from COPD, and in 1990, COPD was ranked 12th as a burden of disease. So after 25 years of smoking, at least 25% of the smokers without initial disease will have clinically significant COPD. So the chronic obstructive pulmonary disorder is the major public health problem, and it is the fourth leading cause of morbidity and mortality in the United States and is projected to rank 5th by 2020 as a worldwide burden of disease. Now, what are the chronic obstructive pulmonary diseases? These disorders are characterized by resistance to airflow. So, there is increase in resistance to airflow due to partial or complete obstruction at any level from the trachea to bronchi to the level of terminal and the respiratory bronchioles. So, they are different from the restrictive lung diseases because the restrictive lung diseases are characterized by reduced expansion of the lung parenchyma and decreased in total lung capacity. So these are preventable and treatable disease. However, they have some extrapulmonary effects. So the pulmonary component of these diseases is characterized by airflow limitation, and that is not fully reversible. So the airflow limitation is usually progressive, and it is associated with abnormal inflammatory response to lungs to noxious stimuli. So the chronic obstructive pulmonary diseases include the emphysema, the chronic bronchitis, the asthma, and the bronchiectasis. So we will be discussing emphysema and chronic bronchitis in this lecture. So the emphysema is the abnormal permanent enlargement of the air spaces distal to the terminal bronchiole along with destruction of the alveolar walls without obvious fibrosis. So fibrosis in majority of the cases is caused by interstitial lung diseases. So as a result of resistance to airflow, there is abnormal permanent enlargement of the air spaces that could either be bronchi, bronchioles, alveolar ducts, alveolar sacs, or the alveoli. And moreover, there is destruction of their walls due to release of certain substances from the inflammatory cells, for example the proteases including elastases. So it has four major subtypes: the centrilobular emphysema, that is also referred to as the centri-Acinar type, the panlobular emphysema, that is the pan-Acinar type, then the paraseptal emphysema, that is the distal Acinar type, and the irregular emphysema. Now, what is chronic bronchitis? The chronic bronchitis, in contrast to emphysema, is the presence of chronic productive cough for 3 consecutive months in at least 2 consecutive years in a patient in whom other causes of chronic cough have been excluded. So, the patients having chronic bronchitis have productive cough with copious amount of sputum, and this cough should be present for at least 3 months in 2 consecutive years. So what are the risk factors of these two diseases? There could be genetic susceptibility to these diseases. There are certain genes that are thought to be mutated. For example, the NRF2 gene that is inactivated in chronic obstructive pulmonary diseases. And this NRF2 gene is a transcription factor that serves as a sensor for oxidants in alveolar epithelial cells. So, as a result of inactivation of NRF2 gene, the patient is prone to develop COPD. Then there is exposure to particles including the tobacco smoke, the dust, the organic, inorganic particles, the indoor and the outdoor air pollutants. Then there could be oxidative stress. And then there are certain diseases that are gender prone. These diseases are more common in males because of habitual cigarette smoking. And at a certain age, these diseases most commonly present in middle to older age. Then respiratory infections, previous history of tuberculosis, low socioeconomic status, poor nutrition, and comorbidities including heart diseases and diabetes mellitus. These are all the risk factors of chronic obstructive pulmonary diseases. So what is the pathogenesis of these diseases? The pathogenesis is highly important, and it is due to certain particles and the pollutants that are released from the tobacco smoke. And these particles are responsible for oxidative stress, recruitment of inflammatory cells out of the capillaries to the alveoli, and then the release of certain substances that can ultimately lead to damage to the alveoli. So this diagram fully explains the pathogenesis of chronic obstructive pulmonary diseases. As you can see that the nicotine present within the tobacco smoke causes the recruitment of neutrophils from the capillaries. Moreover, the tobacco particles also have reactive oxygen species, the free radicals, that are responsible for the release of certain cytokines and chemokines including the interleukin 8, leukotriene B4 and the tumor necrosis factor, which further enhance this inflammatory response, the recruitment of inflammatory cells. And then these neutrophils, whenever they degranulate, they release proteases including the neutrophil elastases and then the leukotrienes that can cause tissue damage in the alveoli. And moreover, they also stimulate the alveolar macrophages to release more elastase and matrix metalloproteinases. So, the tobacco smoke also leads to inactivation of the inhibitors of proteases, the antiproteases. So, this is the basic mechanism in functional alpha 1 antitrypsin deficiency. However, certain humans have congenital alpha 1 antitrypsin deficiency and they are more prone to develop chronic obstructive pulmonary diseases. So this diagram fully explains the complete pathogenesis. The tobacco smoke, which is the most common factor that is responsible for the pathogenesis of chronic obstructive pulmonary diseases including the emphysema and the chronic bronchitis. So again, the pathogenesis, inflammation, so it leads to parenchymal dysfunction, the decreased elastic recoil, and the loss of alveolar attachment. Moreover, in chronic bronchitis, it causes small airway disease and excessive production of mucus and airway inflammation. So the net result of all this pathogenesis is airflow limitation and resistance to airflow. So there is overlap of these chronic obstructive lung diseases including asthma, chronic bronchitis and the emphysema. So what is the major difference between the asthma and the chronic obstructive pulmonary diseases? The asthma is a fully reversible disease, and in asthma there is hyperresponsiveness of airways to the allergens and certain other stimuli. So in asthmatic airway inflammation, there is predominance of CD4 helper T lymphocytes and there is abundance of eosinophils because it is a type 1 hypersensitivity reaction. However, in the case of COPD airway inflammation, there is prominence of acute inflammatory cells including the neutrophils, and then there are macrophages and CD8 T lymphocytes, and the changes that occur in chronic obstructive pulmonary diseases including emphysema and chronic bronchitis, these are not reversible. So the major histomorphological changes that occur in chronic bronchitis and emphysema, as you can see on the right side, the figure A demonstrates the normal wall of the bronchi and the bronchioles that is lined by pseudostratified ciliated columnar epithelium with goblet cells, and then the submucosal mucus glands. So what occurs in COPD? There is excessive production of mucus due to hypertrophy of goblet cells that are present within the respiratory lining. Moreover, within the lamina propria, there is recruitment of acute and chronic inflammatory cells. And then there is smooth muscle hypertrophy, so the wall of the bronchi is thickened. And then there is mucus gland hypertrophy within the submucosal layer that will lead to mucus hypersecretion, as a result of which there is blockage within the airway and resistance to airflow. And lastly, as a result of this chronic irritation, the pseudostratified ciliated columnar epithelium ultimately undergoes metaplasia into squamous epithelium. So, squamous metaplasia develops, and this is again a risk factor for the development of lung carcinomas. So, this is the healthy respiratory mucosa on scanning electron microscopy. So, this electron microscopy shows the respiratory mucosa in healthy state, the presence of cilia, and these cilia beat in a coordinated fashion to remove excessive mucus out of the airways. And this is the damaged respiratory mucosa due to certain allergens or the infections. There is damage to the cilia and the epithelium, as a result of which the normal mucociliary apparatus is destroyed, and as a result of which the cilia becomes less effective in removing mucus from the airways, leading to mucus plugging and airflow limitation. So before discussing the types of emphysema, we should first recall about the pulmonary lobule and the normal acinus. So pulmonary lobule is a cluster of 3 to 4 terminal bronchioles along with its appended acinus. And what is a normal acinus? The acinus is composed of the respiratory bronchioles, the alveolar ducts, the alveolar sacs, and the alveoli. So first of all, the centrilobular emphysema. The centrilobular emphysema, the proximal portion of the acinus, including the respiratory bronchioles, these are distended, and the distal portions are spared. And in Panacinar emphysema, the whole of the acinus is involved from the level of the terminal bronchioles to the blind alveoli. So it is the Panacinar or the panlobular emphysema. The third variety of emphysema, that is referred to as the paraseptal emphysema. In this case, the proximal portion of the acinus is spared. However, the distal portion, including the alveolar ducts and alveoli, these are commonly involved. And these changes most commonly occur along the alveolar septa and the pleura. And then the irregular emphysema, in which there is irregular involvement of the alveolar spaces, and the acini are irregularly involved, and it is associated with scarring. So now the detailed description of the centriacinar emphysema. There is focal destruction that is limited to the level of respiratory bronchioles and the central portion of acinus. And the most common cause of centriacinar emphysema is the cigarette smoking. And the centriacinar emphysema, the changes are most commonly severe within the upper lobes and the apical segments of the lungs. So this is the gross and the micro histomorphological image of the centriacinar emphysema, showing the dilated alveoli within the central portions, while the periphery demonstrates the normal alveoli. And then the Panacinar emphysema, in which the entire alveolus distal to the level of terminal bronchiole is involved, and the changes of Panacinar emphysema are more severe within the lower lung zones, and they generally develop in patients with alpha-1 antitrypsin deficiency. So this is the gross image of the lung parenchyma on the on the right side, in which there is complete destruction of the alveolar spaces and enlargement of the alveoli. Now coming to the distal acinar emphysema, in which the alveolar ducts and alveoli are involved, the distal portions. So these changes most commonly occur adjacent to the pleura, along the lobular connective tissue septa and the margins of the lobules, and adjacent to the areas of fibrosis. So the characteristic findings in this case are multiple continuous enlarged air spaces that form cyst-like structure or the blebs that sometimes rupture to cause spontaneous pneumothorax in young adults. So the apical bullae can cause pneumothorax. So this is again the diagrammatic representation of centrilobular, the Panacinar, the paraseptal, and the irregular emphysema. And these are the gross images. On the left side is the healthy human lung, and on the right side is the emphysematous lung with the apical pleural blebs. This is again the gross photomicrograph showing destruction and enlargement of the alveoli or the air spaces. This is again a hyperinflated lungs, as you can very well see, appreciate the cyst-like structures or the apical pleural blebs that can rupture and are the cause of spontaneous pneumothorax. And the shadows of the lungs is so pronounced that it overshadows the heart, and the heart is not visible on routine chest radiograph. This is the diagram of your Robbins showing the bullous emphysema with large subpleural bullae. And this is again the book diagram, the Acinar emphysema, in which the central areas show marked emphysematous damage surrounded by relatively spared alveolar spaces. And then the Panacinar emphysema involving the entire pulmonary architecture so that the normal alveoli are not visible, because whole of the pulmonary acinus is involved in this variety. And this lung is from the patient with alpha-1 antitrypsin deficiencies, and it shows irregular large air spaces with markedly reduced number of alveolar walls. So microscopically, the abnormally large alveoli are separated by thin septa, as you can very well appreciate here, with only focal centriacinar fibrosis. So there is loss of attachments of alveoli to the outer wall of the small airways, and as a result of these alveolar enlargement, the pores of Cohen, which are normally present within the alveolar basement membrane, they become so large that the septa appear to be floating or protrude blindly into the alveolar spaces. So these are the advanced changes that can damage the vasculature of the lung as well as the lung parenchyma. So this is the normal lung in comparison with the emphysematous lung. This is again the gross photomicrograph showing the normal lung on the left side and the emphysematous lung on the right side. And this is the structure electron microscopy showing the normal bronchial wall without goblet cell hyperplasia and without mucus gland hyperplasia, in comparison with figure B, in which there is mucus hypersecretion with excessive inflammation and mucus gland hypertrophy. So these are the microscopic changes that occur within chronic bronchitis. In chronic bronchitis, there is hyperplasia of the mucus gland layer that is normally present within the submucosa. So we have to estimate the Reed index. The Reed index is the ratio of the thickness between the mucus gland layer and the ratio of the thickness between the epithelium and the cartilage. So it is as you can see in the figure, the BC over AD. So normally the Reed index is 0.4, and in chronic bronchitis this Reed index is increased due to mucus gland hypertrophy. And these are the histological features as I have already explained in previous figures. The goblet cell hyperplasia, the presence of acute and chronic inflammatory cell infiltrate within the lamina propria, the submucosal gland hyperplasia, and the squamous metaplasia that occurs in chronic bronchitis. So this is the figure that is showing the comparison between the emphysema and the chronic bronchitis. Normally the chronic bronchitis presents within middle age and the emphysema in the later age. In the chronic bronchitis, the predominant features are productive cough with copious amount of sputum, mild dyspnea. However, the cor pulmonale or the respiratory insufficiency or the heart failure is more common. The elastic recoil is normal, and the heart shadow is normal in the case of chronic bronchitis, and the appearance of person is bluish, so they are referred to as the blue bloaters. However, in the case of emphysema, the dyspnea is the predominant complaint. the cough develops late, and there is respiratory insufficiency. However, there is later development of cor pulmonale, because in order to ventilate or oxygenate properly, the lungs hyperventilate. So as a result of which, there is later or terminal development of heart failure. So the elastic recoil is low, and due to hyperinflation, there is small heart because the lungs are overinflated, and because the oxygenation is not going to be suffered in patients with emphysema due to their overventilation, their skin appears pinkish and they are referred to as the pink puffers. So this diagram explains the comparison between the chronic obstructive pulmonary diseases, the emphysema and the chronic bronchitis. The patients having emphysema on appearance are thin, lean and slightly older as compared to patients having chronic bronchitis. And why these are called pink puffers? Because they have airflow limitation and resistance, so they ventilate with pursed lips and they overventilate, as a result of which they have hyperinflated chest. They have a barrel shaped chest because the lung that enters into the lung does not go out of the lungs. So as a result of which, they have a barrel shaped chest and their skin has a pinkish appearance. So these terms are now obsolete. So on X-ray, they have a hyperinflation with flattened diaphragms. So why the patients of chronic bronchitis are called blue bloaters? Because of excessive mucus hypersecretion and the blockage of the lung airways. The blood flows back from the lungs to the pulmonary arteries and ultimately to the right side of the heart. So as a result of which, they are more prone to develop right-sided heart failure, as a result of which they have raised GVP, edema, swollen lower limbs and swollen appearance. Moreover, because they are not overventilating, they are having heart failure symptoms. They are hypoxemic and they have hypercapnia and cyanosis. So their lips and the fingertips are blue. So as a result of which, they are referred to as the blue bloaters. However, due to these are older terminologies, they are now obsolete and they are referred to clinically as now chronic bronchitis and the emphysema. So now how we can manage these two conditions, the emphysema and the chronic bronchitis? We have to assess and monitor the disease, we have to reduce the risk factors, and then we have to manage the stable COPD and the exacerbations. So how we can assess and monitor COPD? We have to assess the symptoms, the dyspnea, the cough and the sputum production. As I have already mentioned, the dyspnea is severe in the case of emphysema. However, the cough and sputum is more severe in the case of chronic bronchitis. So we have to, in history taking, we have to be very cautious regarding the history of occupational or the environmental exposure to allergens, the smoking history, the pattern of symptoms development, and the presence of comorbidities, and then the socio-economic status of the person. So this is the MRC Dyspnea Scales, in which we assess the severity of dyspnea. So the dyspnea is graded into grade 1 to 5 depending upon the condition of the person. So in grade 5 dyspnea, the person is too breathless to leave the house or breathless while dressing or undressing. So there are many conditions that may produce chronic cough with normal chest x-ray. So they could be asthma, COPD, endobronchial tuberculosis, bronchiectasis, heart failure, interstitial lung diseases. And then among the extrathoracic cases, there could be gastroesophageal reflux disease and post-nasal drip. So before reaching to the appropriate diagnosis, we have to make a list of the differential diagnosis after proper history taking. So these are the systemic manifestation of COPD. The patient is cachexic, he has skeletal muscle wasting, ischemic heart disease, he is more prone to develop congestive heart failure, then osteoporosis, metabolic syndrome, obstructive sleep apnea and depression. So upon physical examination, as I've already mentioned when I have discussed the pink puffers and the blue bloaters, the person is dyspneic, he is sitting straight forward with barrel shaped chest and he is using pursed lip breathing. The person has wheezy chest, and there is downward displacement of the liver due to hyperinflated chest. And in the case of chronic bronchitis, there is lower limb edema, respiratory distress, and the central cyanosis. So this is the appearance of hyperinflated chest in the case of emphysema, and you can see that the normal shadow of the heart is obscured. So this is now the spirometric classification of COPD. Before assessing the management of COPD, you should be able to understand the FEV1 versus FVC ratio. So the FEV1 is the forced expiratory volume in 1 second. So these two measurements are measured using the spirometer. So these are considered as the pulmonary function test. So forced expiratory volume is the amount of air that the person can exhale forcefully after maximum inspiration within 1 second. And the forced vital capacity is the maximum amount of air that the person can forcefully exhale after the normal or the excessive or inspiration. So this ratio or the forced expiratory volume in 1 second normally is greater than 80%, and if it is less than 80%, so the person is having COPD, and the ratio of these two entities should be less than, if they are normally is this 0.7 to 0.85. However, if it is less than 0.70, so the person has airflow limitation or the airway resistance. However, in the case of restrictive lung diseases, both of these two values decrease proportionately, so as a result of which the ratio remains normal. However, if the FEV1 alone is decreased or the ratio is decreased, the person has COPD. So this is the bronchodilator reversibility testing that you will be studying in your medicine wards. That bronchodilator should always be given by meter dose inhaler, and the possible dosage protocols that are normally set approximately 400 grams of beta 2 agonist to up to 160 gram of anticholinergic or combined. So after the administration of bronchodilators, FEV1 should be measured after a short-acting bronchodilator and approximately 30 to 45 minutes after the combination. So now the lung volumes and the capacities. The three lung volumes that are most relevant to COPD are the forced vital capacity, the residual volume, and the total lung capacity. So these are the lung volumes and capacities. The vital capacity is the maximum amount of air that can be inhaled or exhaled during normal respiration. It is the maximum amount of air. However, the tidal volume is the normal volume of air that can be inhaled or exhaled during inspiration or expiration. The inspiratory reserved volume is the extra amount of air that can be inhaled after inspiration. It is the extra amount of air that can be forcefully inhaled. However, the expiratory reserved volume is the maximum amount of air that can be exhaled after maximum forceful expiration. So the residual volume is the volume of air that is remained within the lungs after maximum expiration. So these lung volumes and capacities, they are measured through spirometry, and their decrease or increase may suggest the possible lung etiology. So now arterial blood gases should also be measured, and decrease in saturation of oxygen or increase in saturation of carbon dioxide indicates hypercapnia, and it should be managed accordingly. So now the chest x-ray, as you can see, there are low set diaphragms, hyperlucent lung fields, and the heart assumes a vertical shape. So differential diagnosis of COPD, as I have already mentioned, is the asthma. The onset of asthma is early in life, and it is mostly hypersensitivity response to allergens. So the patient is prone to have allergic symptoms, the rhinitis or eczema, or the family history should be present. However, in the patient with congestive heart failure, clinically has the presence of basilar crackles on auscultation, and on chest x-ray the heart has a dilated appearance. However, in the case of COPD, the heart is shrunken due to hyperinflated lungs. While in the case of bronchiectasis, the chest X-rays show lung infiltrate due to inflammation or infection, and there is microbiological confirmation of bronchiectasis. So how we can reduce the risk factors? Smoking cessation, we have to reduce the occupational exposure and the exposure to indoor and the outdoor air pollution. And how can we help the person in smoking cessation? We have to ask, advise, assess, and assist the patient in quitting smoking, and we have to arrange the possible ways in which the person can quit smoking and also schedule a follow-up contact with the person. Then COPD risk and smoking cessation. If the person is having smoking for a large period of time and he has stopped smoking at the age of 65, then he has more prone to develop severe COPD. So we have to quit smoking at the person should quit smoking at an early age in order to reduce the severity of these diseases. So management of stable COPD, pharmacological therapy, the long-term oxygen therapy, pulmonary rehabilitation, nutrition and surgery, the lung reduction surgery. So among the pharmacological therapy, there are bronchodilators, the methylxanthines, the steroids. So the bronchodilators available are the beta agonists, the anticholinergic drugs, and the methylxanthines. The most common beta-2 agonist is the salbutamol or the Ventolin that is used as an inhaler. And among the anticholinergic, the ipratropium bromide that is commonly available with the name of Atom. And among the methylxanthine, the aminophylline, most commonly available cough suppressant syrup. The Acefil cough syrup has this agent, and these are most commonly used syrups and the inhalers by the COPD patients. So the types of inhaled corticosteroids, the Clanil, and it is most common, Clanil A compositum. It is available in the form of boils that can be used in nebulization. Then there are also other corticosteroids that are available. So the management of stable COPD, depending upon the FEV1 and the FVC ratio, the COPD is divided into mild, moderate, severe, and the very severe disease. So we have to do regular treatment with one or more long-acting bronchodilators, and when needed, add rehabilitation or corticosteroids if repeated exacerbation, and add long-term oxygen if chronic respiratory failure, and we should also consider surgical treatments in patients having respiratory failure or the severe COPD. So the long-term oxygen therapy improves the survival, the exercise, the sleep, and the cognitive performance. And the therapeutic goal is to maintain saturation of oxygen above 90% during rest, sleep, and exertion. So rehabilitation, for the lungs to get more air, we have to use the pursed lip breathing technique, like breathing out slowly into the straw after maximum inhalation. And then the diaphragmatic breathing, sit comfortably with after relaxing your shoulders, and put your one hand on your abdomen and then inhale slowly through your nose, and then push your abdomen out while you breathe in, and then push in your abdominal ulcer muscles and breathe out using the pursed lip technique. So these are the normal lung exercises that are used in rehabilitation. And then the nutrition, we have to improve the nutritional status of the patients having COPD in order to maintain an optimal BMI. And then there are certain lung volume reduction surgery in patients having overinflated or the hyperinflated lungs. So now coming to the COPD exacerbation. Exacerbation is defined as an event in the natural course of disease that is characterized by the change in the patient's baseline dyspnea, cough or sputum that is beyond the normal day-to-day variation, and it is acute in onset, and it may warrant a change in the regular medication in a patient who already has COPD. So cause can be anything: failure to stick to treatment if the person is non-compliant and he has developed a certain respiratory infection, or if he has exposure to certain allergen, and if the person has started smoking again, which he has already quitted, or if the person has comorbid conditions including the cardiac disease, the diabetes mellitus, and then inadequate antimicrobial and the inflammatory therapies. So we have to manage exacerbation after taking proper medical history and assessing the signs of severity, including the respiratory failure, the cyanosis, hypercapnia. So what are the indications of hospitalization in acute exacerbation? If the patient has long-standing COPD, he has comorbidities, he is of older age, and there is insufficient home support, and failure of sticking to the initial medical treatment, and if the person has developed arrhythmias. So the indications for ICU admissions are dearrangement of the air-blood gases. So there is hypoxemia or hypercapnia with respiratory acidosis despite supplemental oxygen. So there is indication for invasive mechanical ventilation, or if the patient has changes in mental status. So this diagram shows the management of exacerbation of COPD, that if the patient has moderate to severe exacerbation or there is FEV1 less than 50%, then inhaled bronchodilators and IV steroids should be added, IV antibiotics should be considered, regular ABGs should be monitored, also chest x-ray, CT chest to exclude pneumonia, hemothorax or the heart failure. And if the patient has hypoxemia, then use oxygen to achieve appropriate saturation. However, if there is hypercapnia and respiratory acidosis, then this patient is the candidate for non-invasive positive pressure ventilation or the ventilatory support. However, if there is mild exacerbation, then we can increase the dose of bronchodilators or short course steroids, or if the patient has developed certain infection, then antibiotics could be given. Thank you so much.